Okay. Welcome to today's meeting of the External Services Select Committee at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by external organisations and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm the chairman of this committee. Welcome everyone. So before we start, I've got some important housekeeping for everyone who's present in the room. Please ensure that your mobile phones are on silent. We're not expecting a fire drill, but if the fire drill goes off, please follow Nikki out of the building, even if she jumps out the window. Please keep your microphone muted when you're not speaking and then unmute to speak. As chairman, I will call on those to speak. And we're trying a hybrid meeting tonight. People who are watching will notice. So if anybody has any feedback on how they thought the hybrid meeting went in terms of viewing it, please do contact Nikki and let her know. But we're hoping it's going to go very well. Okay, let's move on to the agenda. Do we have any apologies for absence?
Chairman, there are no apologies for absence.
Thank you, Nikki. Do we have any declarations of interest? No. Fantastic. Everything is in public, if I'm correct. Yep, thank you, Nikki. Are the minutes of the meeting of the 27th of January agreed? Agreed. Fantastic. Excellent. Okay, that's great. So we can go on to our first substantive item, which is about the Hillingdon Health and Care Partners. Essentially, this is a newish adventure in Hillingdon, which is probably about a year old, I'm guessing. And we haven't actually had a presentation on it at this committee yet, because we wanted the HHCP to sort of embed a bit. So we're really interested in hearing about what the HHCP is about and what hopefully it might be able to achieve in the future. So Caroline, would you like to tell us all about the HHCP?
Yes, certainly. Thank you very much. And apologies that I can't be with you in person tonight. It sounds like an award ceremony, doesn't it? Apologies I can't be with you in person tonight. Unfortunately, it's a far less glamorous reason than that. Unfortunately, I've tested positive for COVID, so I am following all of the guidelines. So I really appreciate Nikki sort of setting this up at a relatively last minute. So hopefully this goes well. It does mean, however, I can only see a certain number of you. So if there's anyone gesturing that I can't see, if you could wave or shout, that would be brilliant.
I'm happy to field that, Caroline. So if I see somebody, I'll let you know. Thanks.
So what we are going to do a bit of a partnership act on all of this, because I think what's really important about Hillingdon Health and Care Partners is that it is just that it's a partnership of organisations across Hillingdon Health and Care, the health and care system. So hopefully that will come through in the presentation as we run through tonight. But I was just going to start off on the first slide with doing a quick bit of a recap. I think I did do a bit of an intro to some of the stuff around integrated care at the meeting about a year ago now, but it was in relatively early form, and obviously we were kind of mid all of the COVID pandemic management. So I'll just do a kind of quick overview of who we are and what we're about, really. So we're an alliance of health and care organisations in Hillingdon. You'll see all of the logos there. So Hillingdon Hospitals, the Confederation CIC, which is our primary care membership organisation of most of the practices in Hillingdon. CNWL, who deliver our mental health and also our community physical health services, and H4All, who are our third sector collaborative organisation and give us a really fantastic route into working with our VCSE sector in Hillingdon and bring a real richness to our services that we deliver. So those organisations have been working together now for probably about a couple of years under something called an alliance agreement, which gives us a structure around our partnership and allows us to do things like share budgets, join up our operating models, and really deliver sort of truly integrated services. We've got two partners that aren't within that alliance agreement, but that we do work really closely with, and increasingly closely over the last couple of years, and I think some of that will come through in a bit further down. So we work really closely with London Borough of Hillingdon, both in terms of the kind of the planning and the strategy around things like joint health and wellbeing, but also on an operational basis around some of our work, initially on older adults care, but increasingly now looking at our children and young people and how we can join up care across both health and social services. And also, of course, North West London Clinical Commissioning Group. So previously that was Hillingdon Clinical Commissioning Group. But as we know, all of the clinical commissioning groups have moved to align to our integrated care system footprint, which I'll come on to in a second. So we now have a single North West London CCG. But our borough team, we're really fortunate. A lot of the people that were in the Hillingdon clinical commissioning group are still in the system in Hillingdon and continuing to deliver and support all of the partnership working on the transformation schemes. So that's a quick overview of who we are. We've got our strategic aims. So broadly speaking, there are 3 of those. One is around delivering outcomes for improving our outcomes for our population, and that really stems from our joint health and wellbeing strategy. There was a piece of work done to refresh that, but really what we're looking to do as partners is look at outcomes and delivering as much as we can to improve across the patch, but also try and redress some of the inequalities that we might see in health and care outcomes across Hillingdon. So that is a key part of our reason for being. We are really driving the delivery of sustainable, person-centred and joined-up models of care. So, again, we'll come on to a bit more information around some of that, but putting people at the centre of how we deliver care, really, rather than some of the pathway-based and service-based approaches that we've had to delivering care, and making sure that all of that aligns to the new hospital plans and assumptions within the activity, so that, again, we've got a partnership view about what we're all delivering and that we're really clear about which bit of the system is delivering which bit of that picture. And also, of course, we are part of the North West London integrated care system, so delivering the priorities that they are sort of deemed to be most important across North West London, keeping Hillingdon in track with some of those priorities and delivering those locally through the models of care. And I'll hand over to Dr. Prasad, who's going to just talk about our delivery models, one on the neighbourhood level and then one in terms of some of our joined-up borough services. So, Ritu, over to you.
Hello, everyone. I'm Dr. Ritu Prasad. I'm a GP in Ruislip, and I'm the chair of the GP Confederation in Hillingdon. And we are one of the partners of the Alliance, as Caroline's just explained. So, over the last 5 years, I think we've been working together as partners to develop new models of care which are more patient-centered, and also to develop joined-up care as well, working with partners just to have better economies of scale, to work at scale with various projects. So part of the projects that we have been delivering, one is a neighbourhood model, which I will go into a little bit more detail, and then there are these joined-up transformational projects which we've been running with partners. So the neighbourhood teams are actually 6 teams. We've got 6 PCNs or neighbourhoods all across Hillingdon, which comprise of GP practices and their population. And it varies from a population level of about 35,000 to about 82,000, one of our largest networks. So these PCNs are basically practices joined up, and the idea behind that is that not only do practices join up, but we also join up with our partners who provide a lot of the services like CNWL, H4All, and also from the hospital end as well. So this is the neighbourhood teams, and the sort of foundation blocks of the neighbourhood teams were the development of the Care Connection teams. So the Care Connection teams was a joint project that the GP Confederation has with CNWL, our community provider, and we've got teams with guided care matrons, care coordinators, and H4All with their are also involved in the partnership with the health and wellbeing officers. And this is a team of GPs and these 3 groups of people who provide care to the top sort of 1 to 5% of the high-risk patients, and with the view of developing a resource within the community to provide good patient-centered holistic care and to prevent any admissions unnecessarily as well. So this was expanded, and we've joined it up with the community mental health liaison teams as well. And the idea is that we start building around this model so as to incorporate teams which are like, it could be specialist community-based cardiac failure teams or respiratory teams, and we can carry on expanding it. So we're keeping the patient at the center. We have a model of care where we jointly work without any kind of organizational boundaries. So that's part of the neighbourhood team. The other sort of models of care that we have developed one is at the hospital end, which is the integrated discharge team, which works very closely with the A&E departments and the CNWL and also H4All, and that is to prevent any unnecessary A&E admissions and also to discharge patients safely into the community. And to that end, we've also developed increased capacity in the community beds, rehab beds as well. There's also teams working with the A&E teams, which is the high-intensity user team, which is led by H4All. And what these teams do is they look out for people who are having recurrent sort of A&E admissions, because there's a lot of social and mental health element to patients who keep on presenting to A&E. So they give a dedicated support to these patients to prevent them their recurrent sort of admissions into hospitals. We've also worked up with Hillingdon Hospice and Michael Sobel and developing a community-based end-of-life care package as well. There is so all of these teams, they join up, and alongside with this, we also have the care home service, which is again a partnership with the Confederation and CNWL, where we have a team of highly skilled nurses, care coordinators, pharmacists, GPs, who support the care homes and look after the patients with development of holistic care plans and with advanced sort of directives and incorporating and involving the family and carers and the care homes as well. So this is part, so it's a kind of a joined up scheme, and what we're trying to do is develop all these models so that we can join them up and that they work really in a cohesive manner across the partner organizations. So this is just a summary of few of the sort of integrated teams. The other parts also that the hospital, THH has been working with the GPs as well, is integrating some of the clinical services as well. So that's part like your pediatric service, and when we are developing the model for the CYP across the borough, this will also help in bringing together various schemes which are run by local authorities, CNWL, the hospital and general practice, with the aim of working together and sharing learning and experience and supporting each other. So that's kind of a swift overview of what we've been doing, and I'll hand back to Caroline to take forward.
Thanks, Ritu. So all of that we'd already sort of set up in Hillingdon and got running, and what's happened in the meantime is, if you go on to the next slide, Nikki, is that national policy sort of caught up with us. So whilst what we're doing in Hillingdon sort of came out really of a conviction about how providers and organisations in Hillingdon could work together, it's got a really clear national direction of policy supporting it. So it really stems back from the long-term plan that came through in January 2019, but you can see that we've had sort of more recent guidance, particularly just a couple of weeks ago. So the latest paper that came out was this health and social care integration, all of which sort of started to set up how we can integrate it at system level, and then the most recent paper really focused on place, which is what we are in Hillingdon. So in the sort of jargon of the policy as it's being developed, Hillingdon sits at place, North West London sits at system level. So sometimes it gets a bit confusing when we talk about system as to which we're talking about, but Hillingdon as a borough is place. And the white paper set out some really clear areas that we need to focus on. So one is around establishing shared outcomes and priorities at a local level alongside the national commitments. And as I said, we've already done a lot of work around that with the Joint Health and Wellbeing Strategy, which we'll come on to, which I think puts us in a really good place. It starts to set out what the local leadership and governance might look like, and having that in place by spring 2023. Talks about further development of financial alignment and pooling, and how we can really bring our resources together and use them to best effect to put those models of care in place across health and social care, and hopefully get resource to where it's needed. And also it specifically calls out plans for local workforce and digital to enable those new care models. So all of that really complements the work that we've been doing in HHCP, and gives us a really good platform then to start to plan what 22-23 looks like and how we move that forward. Just a bit then sort of more practically as to actually what this means Ritu's talked a bit about some of the services, but what we've found is that during COVID, actually, the partnership working brought some real benefits and impacts. And I can't see her, but I'm hoping Vanessa's in the room and will kind of take us through those.
Thanks, Caroline. I'll move that slightly. So I'm Vanessa Odlin. I'm the Director for Hillingdon and Mental Health, and I work for CNWL. I've got the joy of sharing the positive impacts of the partnership working. So I think probably one of our kind of biggest successes has been one of the highest vaccination uptake rates in London, and actually we've seen that by working all of the teams across the HHCP working together and actually breaking down those barriers and actually seeing that in practice. And actually seeing and understanding when someone needed something in one part of the borough, the team almost coming together and kind of moving to wherever they were needed to undertake that vaccination. That also supported us in some of our inpatient services where people needed that vaccination. So that was certainly one of the kind of highest achievements we feel for us. We've also been able to respond to the pressures across the system, including the care homes, across physical health and mental health, and enabling discharges out of the acute trust to make sure that we've continued to support the acute trust. We've also been able to use our teams flexibly, so much like the kind of model that we used for the vaccination uptake and the teams coming together, we've been able to use our teams flexibly in that way to support our services as well. In addition to the implementation of advice and guidance for the planned care. And I think the kind of what's next for us is around kind of understanding our population health data and really understanding what our communities need so that we can use some of the models that we've already developed to wrap and be flexible how we develop our care for communities. And as we've said before, to kind of look at how we strengthen our relationships across all of our partners, and so that's not just at our senior level, that we do that with our staff on the ground as well. Back to Caroline.
Thanks, Vanessa. So we've got some really kind of tangible benefits over the last year, but the sort of strategic part's really important, and as I said in the white paper, it sets out really clearly the need for shared outcomes and a joint ownership of that across health and care. And Kevin's been working really closely with us on that as we've done a piece of work around the Health and Wellbeing Strategy and the Health and Wellbeing Board. So over to Kevin.
Thanks, Caroline. Yes, good afternoon, good evening, rather, everybody. So I'm Kevin Burnham. My role is Head of Health and Strategic Partnerships at the Council. So I wanted to come along this evening to offer our support for the development of HHCP and to reinforce the fact that we see the local authority as being integral to taking forward health and care in Hillingdon. So we've, as Caroline said, and you've seen really through the slides so far, I think, the local authority has been cited several times in terms of our role around social care and public health and how important that is to ensure we do move forward this strategy and our approach together. What we've done in the manifestation of that, if you like, in the last year, 18 months, has been particularly around developing our joint health and wellbeing strategy, which we published just before Christmas, and that we now see as being the overarching strategy for the leadership of place when we talk about the borough as being the place. We've also, and you'll see on the slide there, the 6 priorities that we've identified as being important to the borough, which we have consulted on and developed together, and they form the basis for the business planning which is contained in the strategy as to how we take forward some of the more practical elements of the partnership. The strategy reports directly into the Health and Wellbeing Board, and we've also spent some time over the last year looking again at that board to make sure that it was fit for purpose as a partnership structure rather than a council committee. We spent a lot of time in trying to work with our partners here to position that so that we can have the right forum to discuss issues that occur locally, and for it to be a place for bringing issues for further debate and resolution and all sorts of discussion, rather than being a committee that just approves papers, and that's working well so far. We've appointed Caroline as joint chairman of that board alongside Councillor Palmer, and again that's working well. So the governance structure is pictured in the diagram, which you might be able to see in that slide slightly, but the Health and Wellbeing Board is the yellow blob in the middle at the top, which we see as being the top of the pyramid almost, and with the various governance structure that sits beneath it, reflecting the various transformation themes that are being delivered through HHCP. It's probably worth pointing out that the yellow box to the left of the diagram, which says provider boards here, reflects the fact that each of the individual partners have a sovereign identity, including the local authority. Obviously, we report through to the council, through cabinet to the council. So this structure is very much about partnership working rather than just decision making, because a lot of the decisions that are made on financial investment will be referred back to individual sovereign authorities. But what we've got now is a plan to take forward health and care in Hillingdon. We've got one plan, and we will report against it in terms of a single performance report too, which we take to each Health and Wellbeing Board. And we put a lot of effort into trying to make sure that that is seen as being the place where all this sort of comes together. So yeah, I think, as I say, I think it's gone well so far. There's obviously lots more to do, but we do see the local authorities being integral to all of that moving forward. That's all I have to say.
Thanks, Kevin. So that gives us the sort of strategic framework and the kind of plan that we're working to. But then on an operational level, as I said previously, one of the things we know we want to focus on is our models of care, and really truly joining those up around individuals and around communities, which we know we've got a sort of bit more thinking to do about. So, Steve, I think you're going to take us through this slightly psychedelic slide on the left there.
Yes, thanks, Caroline. I'm Steve Curry. I'm Chief Executive of Hillingdon Hospice and Michael Silbell, and he is the third sector rep from Edge for All. As you can see, there's two very different diagrams on that slide there, and this is very much a piece of work that we've been working on as a priority in terms of setting ourselves a direction of travel. So this is about the diagram on the left is how we function at the moment. So as you can see there is a lot of crossover in terms of partnership working, but actually most of the pathways that support people, particularly through health, are actually organisational led and are within a single organisation, which leads to gaps in services where people's needs are not met, and also duplication. So we've done a lot of work around developing this new pathway to take us forward, and what we've done is we've gone right back to basics and work out what is the population need, what is the population health need, and we've looked at when people use services and what services they use, not why they're using them. So we've approached it very much from a person-centred point of view rather than an organisational point of view, which is currently how it's structured at the moment. So we've identified 6 main areas which are on that diagram on the right there, which is taking everybody from the cradle right through to the grave in terms of that early start right through the end of life. But the bits in the middle are about keeping a population healthy and well, and very much focused on health promotion and as well, but also being very clear that when people do need to use services, that we've got the right services in place. So this is our roadmap about how do we actually sort of, our framework for which we're looking at how do we take what we're currently doing and then look at using this as a basis to develop the transformation that we need to do to actually move to a truly population health-based service for the population of Hillingdon. Thank you, Caroline.
Thanks, Steve. And then moving on, the other piece of work that we've really focused on a lot this year is aligning all of the transformation programmes that we're delivering with the new hospital build, because we know that is just such a critical opportunity and priority for us in Hillingdon. And as much as we can do to join up all of the delivery and transformation plans and the clinical models of care, the better I think presented we are as to how we take the business case forward. So Jason, I think are you able to talk a little bit about the process we've been through?
Thank you, Caroline. Does it work? Yes. So this is a big thing for me today of having a microphone that works. So just picking up on what Steve has said. So there is a key piece about how we are all working in partnership about how we're going to transform services, very much shaped around the patient, where probably traditionally a number of services have almost been almost institutionalised around the organisations. So there's a key piece now over sort of the coming years about how we really do truly sort of transform ourselves at that place level. As Caroline sort of has mentioned there, the key piece there then is for us not to be doing this in isolation of all the different things we're doing as organisations. So the piece hopefully we can provide assurance for you here today is that we are very much grounding all the work that we're doing on the new hospital around how our services are working at place level. So I think in terms of previous discussions we've had here, it's not just looking about how we're building a new hospital, it's how we're building a new system of care for our local population which better serves them, but we'll also have a new hospital which will house those services. So just in terms of the sort of multicoloured headlines we have there, there are sort of 6 sort of key areas there in the transformation plan. So I think the piece earlier that we referenced around primary care networks, emergency and urgent care. So again, it's one of those pieces that if you did historically look at how emergency and urgent care activity has sort of played out year on year, there's almost an element of hospital admissions going up and up and up. And if you're building a new hospital, if you took that linear approach is, well, gosh, you'd have to build a jolly big hospital. And the refreshing piece that's really recognised by the sort of new hospitals programme at the centre is that they can see how we're all coming together to ensure we're developing the sort of the more joined up services. So there's a key plank around that. Planned care, again, very much working together on mental health, children and young people, and the end of life care. There is probably to the side, which I won't profess to try and read from here, it's like being at the opticians, can you read any of the numbers? And I'd say sadly not. But that diagram there, just again from an assurance perspective for the committee here today, is that what we're looking at is sort of what are the key headlines for activity and demand projections going forward, and about how we work as a system together about managing the needs of our local population. So it's again a key piece that sort of Steve was referring to earlier, of we're working out those assumptions together, so we're not seen to be planning separately. So I think it's really exciting times what HHCP is doing, and it's sort of well regarded from a new hospitals programme perspective of a really good piece of work about how the partners are working together. I'll pause there, Caroline, and we've just got to say what a sterling job Caroline is doing tonight of, she's, carrying on regardless, yes.
Thanks, Jason. I may become less coherent as we go on, so we'll see how we get on. So just in terms of then next steps, and hopefully what we've given you is a bit of an overview of sort of where we've come from as HHCP, why we came together to start with, and what our sort of current aims are. But then in terms of our next steps really is, we've got a chance now to very much focus on population health and establish our sort of key areas from the work that we've been doing around things like the Joint Strategic Needs Analysis. We're also a pilot area for some population health work that NHS England are leading on. So again, all of that work around sort of neighbourhood, primary care network, population development, we can embed and start to roll out through that. Development, going back to what Steve was saying, development of our models of care and our integrated neighbourhood operating models, continuing to kind of map and deliver our transformation schemes against the joint health and wellbeing strategy in the new hospital, but then also really further building our joint approach to enabling work streams, because I think we've started a bit of it, but I think we've got a lot more to go at in terms of how we work collectively around things like workforce planning, digital development and estates, and how we make best use of some of the really fantastic people and resources that we've got in Hillingdon, and do our best to sort of recruit, retain and develop people within our teams. And then, just finally really working with North West London ICS so that we are sort of partners in shaping and developing what the future state for place care is, so that Hillingdon is around the table and part of shaping that. So I'll stop there for any questions, but I hope that's given you a kind of a whistle-stop tour and a bit of a taste of HHCP.
Well, thank you very much, Caroline, and I think it was absolutely fantastic how you showed partnership working by getting lots of other people to do work as well on your presentation, which I think is absolutely brilliant. When I first started doing this job a while back, I think this is exactly the type of thing that I really thought was necessary, because ultimately I've never come across an organisation as complex as the healthcare delivery network that's needed. But that's partly because people's issues are very complex and different. But many great people doing great things, but the alignment seemed to me to be one of the things that's missing. So this is an absolutely important but a huge job. So it's really positive to hear what's happening with it. So I've got 3 questions, and I'll open up to the rest of the committee. My first one is about the patients, really. So you've got North West London, which is systems. You've got Hillingdon, which is then place. And then the patient is the personal, I suppose, underneath that. And what does putting people at the centre mean to that person?
So I'll start, and then maybe Ritu might want to, or Steve and others might want to jump in. So I think it's a really good question, and I think when we talk about population health as well, sometimes the person gets lost, and we had a bit of a chat about this at a meeting earlier this afternoon. So there's a couple of things. I think one is going back to what Steve was saying about understanding why people are using services rather than which services that they are using, and trying to sort of develop a system which makes it actually intuitive and easy for people to actually get the care that they need when they need it and in the right place. I think we, over the years, with the way that health has developed, we sort of set up multiple entry points, lots of front doors to things, which then end up signposting people around, and just taking a step back and thinking, actually, how do we coordinate care for people and get the right information out to people to know what is available to them, and then support them to access and engage with that information is really key. It doesn't necessarily actually need to be health professionals doing that, and some of this is about how we work with our communities, work with some of our VCSE colleagues. We've got some teams, we've got community connectors now, community champions that work through the bids that have come through post-COVID. We also have health connectors in Hillingdon, so there's a whole sort of workforce and approach about how we can now move forward probably post-COVID and get that information out, but also hear back from people about where there are gaps and things that aren't working. And then on a specific level where people have care needs, it's how we work with people to plan what those care needs might need proactively, so that we don't get to a point where something, there's a gap, something goes wrong, and then someone's left not necessarily knowing how to get help, or that, it's the wrong time of day or the wrong day of the week, and therefore, that there's not the support there. It's having a proactive approach to kind of planning for that, and also making sure that that information is available as well. Whether that be through some of the digital work that we're looking at, or sometimes still on a kind of paper base, depending on how quickly something's changing. So I think there's not one thing that puts people at the centre of their care. I think it's us always challenging ourselves about that, and even in how we design services, having that sort of voice in the room, which obviously through COVID has been a bit of a challenge, but going out a bit more now and thinking about how we co-design some of our services with our service users, because we do have information, and we're not starting from scratch on that. We already have some information from previous sort of consultation processes and forums and groups that we can really use and build on. But I don't know whether any others sort of want to add to that.
Vanessa put her hand up first, but then Steve.
So I guess I was just going to add to the population health discussion, and kind of what does that really mean? Because people say population health, but I think people think that's just some data that's over here on a pad of paper, and actually what that means is we really need to understand what our patients, or what our community and people who use our services say what they need. And one of the models that we're looking at in mental health, and it may be something we want to look at wider, is a community connector model. So let's think about how we employ people who live in the Hillingdon community, who want to come and work in, for example, CNWL, and can actually bring some of the services closer, or bring people to the services. I think the second point I was going to make is making sure, so the work we were talking about strengthening our partnership, is just making sure that the CPN who works in one of the community teams knows about H for All, and they know about the services, so when they're seeing someone they can make sure they're signposting people, and that kind of works across all. So those are the kind of 2 points really.
Yeah, just building on what Vanessa was saying there as well, is from one of the challenges we've got is that most of the health data we've got is based on the system as it is at the moment and has been for several years, and actually trying to start to think outside of that and stop thinking about pathways and disease diagnosis, but to think about individuals and the person-centred. So and one of the things we are doing in Hillingdon is we've, from the third sector point of view, HFOL, we've now got a Health and Wellbeing Alliance, which has got over 80 of the local voluntary and community groups involved in it, we're actually getting information from that to feed back into the system. The other ways we like some practical stuff in terms of trying to break down some of the barriers that moving to technology has actually happened. Because previously we were working on paper-based situations. If somebody was getting care at home, then there'd be a file in their home which the district nurse would write in, one of our care staff would write in. Everybody could see everything. At the moment, we're all on different systems, so we're actually working very hard to actually read access to each other, so we can reduce that side of things. Then the other bit is about coordination, so it's actually making sure people can have access to it, because particularly as people get older and they've got more and more diagnosis and conditions, then they actually could end up in several of these sort of streams. So you actually are not being seen as a whole person, you're just being seen as in bits by someone. And that creates, particularly as you're getting older and more frail, it creates a very much more complex system to get around. So one of the things we're working at the moment on end of life is to reduce to have a single point of coordination. So there's one telephone number that you, your carer, or even the healthcare professionals can phone. Because as you said earlier on, as a system at the moment, it's a very complex system to navigate around. Even us who work in it have difficulty when we have our own needs to actually be dealt with. So it's actually taking a step back and looking at how are people using the system, how are we preventing the system, how does the system prevent us to actually really help them get well, and it's actually moving back to actually what do we need to do is wrap around the care around the person and the community, because that's the other thing is Hillingdon isn't a homogeneous community. There's lots of different communities in Hillingdon. It's making sure that we can flex around all of those needs.
Thank you. Ritty, did you want to say something? I think you're on mute.
Sorry. Okay. So just to add to that, I think from a patient's perspective, it is the patient being involved in the team as well. So it's the patient empowerment which comes with that kind of support that we give in a joined-up manner. So a patient, from a patient's perspective, they don't have to tell their story again and again to different people because the team knows them and they feel part of the team. And the ultimate aim is not only to empower the patient, but anybody who's looking after them, be it any family member, is that kind of empowerment. And that's the whole team, including the patient. So it's just not about health and social care, but the person as well. So that's the aim of what we are all trying to do, and make it a much more cohesive and a much better service, because unless we involve patients in all of our projects, we are again back to square one. And that silo working, which Steve just referred to, parts of your body, like, okay, I'm going to look after this, that goes. Because not every need of the patient is health related, they have complex needs. And when we work in a team, we are able to share that and then address their problems. Because you may fix the health problem, but if you've not fixed a social problem or a mental health problem, that person's never going to have a better quality of life.
Yeah, I mean, that's 100% correct. I think something maybe for the future, something that certainly interests me is, what is the patient experience now, and in a year's time, this is the patient experience now compared to, to see the movement that this partnership working can hopefully create would be very good. My second question sort of is related to what's been discussed. It's about data. How do we use data to make decisions about what can create a better healthcare system in Hillingdon? Big question, but I just think it's because obviously there is lots of data, but it would be extremely useful for that data to help drive decision making, and then obviously to hold people accountable to the data and assess what's going on. So, Caroline, would you be able to start off with that?
Yeah, of course. So we are quite fortunate in North West London in that we have something called the Whole Systems Integrated Care, or WSIC database, which is, I think, one of the biggest linked data sets in Europe. This was a few years back. There was a lot of work done joining up all of the data flows in from primary care, community care, secondary care, mental health, and also local authority services. So there is underpinning North West London a kind of linked data set that we can access to look at sort of on an appropriate level, obviously, to look at population health data. So that's anonymised. It doesn't show you people's information. It just tells you at a borough level sort of how we're doing in terms of particular outcomes or activity or particular disease management, and looking through that. So I think it's something that, and also I should say, clinicians can look at it in a more detailed level, and they can drill into data on a patient basis, again, from a kind of practice perspective, to see where they might want to sort of prioritise in terms of bringing people into support around long-term conditions and medicines management reviews and that kind of thing. So we do have data at our fingertips from that perspective, but then we also have increasingly access to some really granular public health data. And I think one of the things that we've done through COVID, probably more than we had done before, is use local authority and public health data across boroughs, across the borough, which breaks down to the lower super output areas, which of course doesn't quite align with our neighbourhood models, because that would be far too easy. But broadly speaking, what we're trying to do, and what we're trying to do through the kind of JSNA process as well, is as much as we can align our data and our population data to those neighbourhood teams, so that on a sort of population basis across those 6 neighbourhoods, those teams can see how they do in terms of some of those key management indicators, whether that's diabetes management or health checks for people with severe mental illness, and how their particular neighbourhood is performing compared to other neighbourhoods in Hillingdon, but also across North West London as well, so that we can see where there's variation and where we want to improve that. So that's on a quite a, I suppose, operational level from a kind of neighbourhood and network perspective. And then on a sort of place basis, the piece of work that we're just doing at the moment is having a look at where we think we can target some interventions that will have a particular impact around inequalities. We're looking at 2 particular cohorts, so falls and frailty, chest pain, and linking all of that data back again to things like the geography of the borough and things like the index of multiple deprivation. So looking at where there are inequalities in terms of socioeconomic status combined with particular sort of communities, and then how that translates into things like activity and into sort of secondary care, when actually ideally we'd want more of that activity to be in a planned way rather than emergency. And going back to that previous conversation really around things being patient-centred, if people are only accessing care when it gets to the point that they sort of are in crisis and need an emergency input, actually what could we have done upstream to try and support some of that proactive care delivery? So all of that data really lends itself to us looking at how that how the resource translates into activity, and how we can move hopefully resource around the system to shift it to that proactive model of management rather than reactive. And the other quick example I'll give is we're doing a lot of work at the moment with children, because we tend to talk a lot about adults and older adults, but we're doing a really exciting piece of work, I think, around the 0 to 19 services in Hillingdon, where we've worked really closely with public health and the performance team in the local authority, and they've given us some really clear markers around where there is variation in some outcomes. So, things like school readiness, obesity in year 1 and year 6. And that's enabled us to look at models in those particular areas of the borough that address those specific issues for those particular communities. So whilst we've got a universal offer, then what we can do locally is say, well, we know that there's a gap in this particular part of the borough where we could focus a bit more resource and really tailor it. So I don't know if that gives you a bit of a flavour. I think we've got a lot of data it's a good question because we could just drown in data, and it's easy to go down rabbit holes. But and I think going forwards, that is something in terms of the framework that we use. But I think we're in a good place, particularly working with public health and some of the performance data about how we really use that to target some of our resource.
Yeah, no, that's good actually. That went in the direction that I was hoping it would go into, because what would be really great is if we use the data to show the power of preventive action. X means less of Y, and do it across a whole place level, shall we say, because my experience so far of the data is quite often silo-based of we achieved A, B and C, which is obviously very important because achieving A, B and C is your day-to-day activity. But if we can have more about the sort of overall systems approach about X equals Y, and it doesn't really matter if it happens in A, B or C, because obviously for the patient they don't really care what happens in A, B or C. That's what he's trying to do. So, I mean, that would be really good if that could be possible. So that work does sound actually very interesting. So that's very good. So my third question, sort of all linked to this sounds like I've planned it, I haven't, I just scribbled it right now, is about accountability. Okay, at the moment this sounds brilliant, and everyone's smiling and giving presentations together and talking very nicely. But what happens if there's a disagreement in the system? What happens if, Caroline, you spot something and say, actually, if we do Y and move this resource from A to C, then we can get way better results over here in Z, and C goes, don't really want to do that. I mean, what happens at that point?
So hopefully, if I did do that, it would be driven by some form of data as opposed to just because it feels like a good idea. And I think it really goes back. I know we do love a bit of governance in health and care, but I think it goes back to the way that we make decisions and decide our priorities. And I think there's the kind of the place space in the decision making that says, look, we've all signed up collectively to what we think good looks like, and it is delivering these outcomes. And I think it's quite important to talk about the fact that it is a shift in terms of trying to move towards outcomes rather than what you were talking about just now, which is activity, and saying, we've done X, Y, Z, tick, that's great, but actually what we're trying to shift is outcome, which I think moves us a little bit away then, or into the realms of being able to have some of those difficult discussions about, well, how do you deliver that outcome? And if we've all agreed to that, which we have, because we've done it through the Joint Health and Wellbeing Strategy process, and we're all sitting at the Health and Wellbeing Board and have committed to kind of hold ourselves accountable for delivering that, then that's the framework within which those decisions would be made. And those decisions would need to be made underpinned by the data that says, well, look, we thought if we did this, if we did X, then Y would happen, but actually it's not happening. So let's go back collectively and say, well, why isn't X happening? And is it about how we move resources around? Is it about this bit of the system needing to do something a bit different? And having that granularity and visibility on the whole process and the system and the impact, which then allows us to unpick it. I think, like you say, it looks great because we're all sort of around the table and involved, but we have had difficult conversations, so I wouldn't want to sort of shy away from that. And I think sort of strategy and relationships only come together when you do have some of those challenging conversations, because it's all great to kind of smile and agree, and we are, let's face it, in a context of sort of increasing sort of demand and financial constraint, where we're going to have to think really carefully across all of our organisations and partners about where we do prioritise resource and action, and we have to be able to demonstrate to ourselves and to everyone else that it's the best use of that resource for Hillingdon. And that's the bit that we try and step back from, is to say, is this the right thing for Hillingdon? Putting the organisational piece to one side, that's the test. I don't know if anyone else sort of has a feel for that.
Hello.
No.
Jason is happy to be in. Vanessa, to you.
So just to echo what Caroline's just said, I think the other piece we need to remember here in terms of context is, from a national picture, if you look at how the NHS has been governed, it's probably had a more than a decade, probably a couple of decades, of something called payment by results and patient choice, which a subset of that was almost organisations more competing. It could be seen in some respects. All the legislation that now governs the NHS going forward is very much really embedded about sort of collaboration and about how we work around delivering for patients. And a key piece for that is that will almost be baked in terms of how regulation works going forward. So when we used to have sort of regulatory meetings with a sort of NHS England or improvement, and we were just seen as, so from a hospital perspective, we're just looking at how the hospitals are performing. We now have a system oversight meeting where pretty much all the parties are around the table with a real expectation that everything's going to sort of absolutely be driven forward. I think if we're honest about your question, I think there is a key piece going forward about maturity, us at place level, about how the money works, because you could say, or it could be seen in sort of previous ways when things have been really absolutely seen as, well, that's got to make sense, we've got to do it. Maybe the money's got in the way. I think there's a real maturity, though, in Hillingdon of actually somehow between us we've got to make the money work, because I think that will all be part of joint working. And I think, I mean, talking to Vanessa before we started today, everything needs to join up. So like workforce, where there's scarce resources, all of these things where we used to probably traditionally have more separate budgets. I think over the coming years, from an HHCP perspective, we have to be more joined up, and that will drive the outcomes that we need to deliver.
So yeah, I was going to say it kind of comes back to that conversation around stronger partnerships. So it isn't just saying and sitting around the table and saying, smiling and saying we've got a strong partnership together. Actually, it is working at it, and so that's making sure that we have away days, that we do sit down and have those difficult conversations and don't shy away from them. So it does sound a bit cliched, but it is actually doing that in practice, which actually does mean that we are able to kind of get through those difficult decisions, because there will be difficult decisions to make. And I guess just to add to kind of what Jason was saying, is we're already doing a lot of the kind of partnership working where we have some of our staff working across other organisations, so we're kind of already seeping into what does that developed workforce look like in Hillingdon. But yeah, I just kind of come back to the point of, just because we're sat here doing the presentation doesn't mean we haven't had those difficult conversations. And I think to add finally that we do have a really strong governance structure, so that's what actually that kind of governance structure does give us, that which then helps with that decision making when it might come to the point where two organisations can't agree on something, and you've got enough organisations around that in the governance to kind of help mediate.
Well, that all sounds good. It's a bit like a marriage. We look good when we go out in public, but actually behind closed doors we will have those honest conversations, and I will be home by 11. Nowadays, with how hangovers affect you when you get older, I definitely am always home by 11. Anyway, right, so Simon indicated. Anybody else?
Thanks, Chairman. It's great to hear more integration, more partnerships working together. I often hear from residents where usually they've got complex medical issues and they're under the care of one or two or possibly even three hospitals, and then they'll get letters to come in and see a various consultant, and sometimes all of those meetings are on the same day. And then when they phone the hospital to reschedule, the hospitals get annoyed because they said, well, it's a very senior consultant, they've come in specially, you need to make this meeting, but they can't because they have to be. Do you hope that through this process that more of that will stop?
So if people don't extend, I think the binary answer is yes, and I think hopefully, so if you look at from a patient perspective and you see the NHS lozenge, I think it is maddening about how fragmented is it across all the different organisations that make up this NHS lozenge. And then you put on the TV and you watch the news, and there's a Secretary of State and there's a Secretary of State for Health and Social Care, and so there's almost this issue it all be joined up as well. I think there is now a real push when you compare the learning, probably from other industries, about how health and social care through technology can really be pushed forward. So that question there is the chap who's now in charge of sort of the innovation and transformation for the NHS in England, who's an American who's sort of come across, will almost pick up his phone and just say, in most health systems around the world now, you can press a button, have an app, and that point of it's all there in one place. Whereas at the moment, from a reality, from some patients' perspectives, it's a photocopied letter that probably has been sort of slightly worn in terms of a photocopy. So it's faded, you've got this piece, but then there might be something from Vanessa's organisation as well, there might be Steve's organisation, there's the social care element, and they've almost got a bundle of all these things. And as you say, from a diary place, letting all your family know, trying to work out the logistics, it is just not the way we should be serving the local population. So I think as Caroline sort of mentioned earlier, I think one of the key pieces for us will be that transformation journey together at a place level, and part of that will be joining up our digital systems, because I think it's just crying out to happen now.
June.
Thank you, Chairman. Caroline, well presented, a very good presentation you've done here. I've just got a question on the PC and neighbourhoods. And here it says it's going to deliver localized health and social care tailored to the needs of the local residents. My concern is, how is this going to tie in with the lack of GP services in some areas? And as you well aware, there's no GP service in Hammondsworth, there's no GP service in Sipson. We have in another big build on the Nessa site, there's no GP service tied into that. And then the population that is building around in the borough now, some of them don't have access to GP service. So can you tell me how that is going to integrate in regards to the patient delivery of local and social care tailored to patients and tailored to the community? Because some of those community are elderly people, and it's very difficult for them to get from A to B. So to get from Hammondsworth into West Drayton to see a GP, or from Hammondsworth into Hayes to see a GP, as you well know, that's very difficult. Even though there's public transportation, some of those residents don't have access to that.
Caroline, would you like to?
Yeah, of course. So shall I make a start, and then Rita, you might want to sort of come in around some of the primary care. So it's a really good question, and I think it's something that actually nationally as well people are challenged with, because we know there are workforce issues in terms of GPs and how we continue to meet the growing needs of a population with a constrained workforce. So I suppose there are two sort of elements that I will talk to. One is around, as we start to look at some of those integrated models of care, I think we can start to think differently about what absolutely needs to be done by a GP and what could be done by sort of the broader practice and neighbourhood teams. And increasingly through a scheme that Rita might talk about around was an alternative role scheme. There is funding coming through into primary care to bring in additional and new roles like paramedics, advanced nurse practitioners, mental health team members, so that really GPs are freed up to see really the things that the people and the conditions and the elements of care that a GP absolutely needs to see, and that we therefore have greater capacity from GPs, and as we start to join up some of the models of care, hopefully we use some of those other roles and professionals to support that. And we also know that some people are accessing GPs for things that actually care could support. So how can we look at sort of making sure that we've got access to care rather than into sort of GP and medical support, and some of those models around things like social prescribing link workers. So that's another model that we've got in place, which again is about trying to signpost and support people to access what might support them above and beyond a medical input. So that's one part of it. I think the other part is how we work across our primary care organisations at scale to think about delivering models in a new way. So the PCNs sort of really are opportunities for us to think about joining up resources across practices. So practices are very variable in terms of size, in terms of the workforce they employ, in terms of their catchment. And by starting to work at scale, both at PCN level and Confederation level, which is our sort of single organisation, across Hillingdon, we can look at how we deliver primary care in new models. So one, for instance, that we've just put in place as a pilot is something called Primary Care Surge, which really supports where there's additional demand on practices or additional demand for sort of urgent care on the day type primary care. There's some additional capacity for people to be able to access. And I think the other part is about how we get, how we support people to register with practices. We've got new ways of communication. So we've got digital, we've got online consultation, but we also know a lot of people will still want to do face-to-face. So it's how we have that mixed model of access for people and really use the benefits of scale and some of those new ways of working amongst our community teams, I would say. But Ritu, I don't know if you wanted to add anything.
I mean, you've covered quite a lot. So primary care has changed, and with the development of PCNs, with our additional roles, so it's health and well-being officers, we've got social prescribers, we've got pharmacists, paramedics, podiatrists, dietitians, and physicians associates. So these will be additional resources to help general practice cope with the demand and also the changing needs as well. So these roles, what primary care networks are trying to train these additional workforce is to deal with some of this complex work as well, alongside GPs, while the medical complexity obviously can be held by the GPs, and that's where they are better sort of placed to deliver. But a lot of the work, not only to standardize work, but also to reach difficult areas within a PCN, you have these teams that can go out of general practice and deliver care near where the person is, depending on what the need is. So if it's elderly people, then yes, the PCN would develop a model whereby you could go and deliver that care at that level. Our care community, care connection teams also do that as well. So it's a combination of the new roles and how we incorporate it in some of our transformational models that we've just described, and we all work cohesively so that once people are stabilized, they can be passed on to a less sort of complex team that works alongside patients, and then how we deliver care. So it won't be just practice-based, because practices will join up to deliver care. So it's not like if it's a single-handed GP, they have limited service. All these services will be developed across practices. So it will change, and people will be going out to difficult, hard-to-reach areas of people. A lot of patients who have social isolation issues, because that's where all our additional roles are giving us a helping hand.
Thank you. I have a question on that, but I'm going to save it for the next agenda item, which actually is very relevant to this issue. Does anybody else have any other questions on this agenda item? No, fantastic. Well, thank you very much, Caroline, and the partners who all came here and gave us a really good, interesting presentation. I'd like to propose that maybe in about a year or so's time, you come back and give us an update about what's going on and how it's looking. I think that as long as the rest of the committee agree with that, because I think it'd be really interesting to see how that's happening. People are welcome to stay for further agenda items. They're also welcome to leave if they wish to. So you can make your own choices, and we won't judge you for your choices that you make on this. So, okay, right. So we're going to move on to agenda item 6, which is the progress with GP online consultations in Hillingdon. Obviously, the pandemic has meant a lot of GP services have moved online. We've learned a lot. So it'd be really good to hear about what the future might hold in this regard. Richard.
Thank you very much, Chairman. Thank you. I'm Richard Ellis. I'm Joint Borough Director for the NHS Hillingdon team within the North West London Clinical Commissioning Group. And I think in lots of ways our previous discussion has touched on a lot of the philosophy and the approach of online consultations, digital consultations. The population health aspect, the purpose of reaching out maybe to underserved communities that have difficulty accessing a GP, and I think fundamentally putting the patient at the centre, your point, Chairman, as to how digital services can enable putting the patient at the centre and putting the right practitioner in touch with the patient, which I think was partly Councillor Arnold's point about the different synchronisation, the different sequencing of appointments, and of course the numerous bits of correspondence that the patient gets. So I think let me just say a word about how we're approaching GP online consultations in Hillingdon, and then I'd really welcome continuing that discussion together. It's fair to say that the general practice in North West London and in Hillingdon have been using online consultations for about 3 or 4 years as part of the GP Forward View, and I think that was remarkable for the level of clinical leadership and clinical input in thinking about a model for online consultations. It wasn't a lot of consultants in shiny suits coming in and selling us bits of kit. It was really trying to start from both the GP and the patient. And I think what was also interesting about the NHS commitment to online investment at that time was the sheer amount of capital that was available to fund equipment, and also something that we were making the case for both in North West London and to NHS London, was the need for organisational development and for training, of course with practices, and we'll talk a bit more maybe later on about practices need to develop and transform their own business practice as part of taking on online consultations. You can't just wheel in the black box and expect things to happen. But what we also spent money and time on was support and engagement for patients and for communities and for patient participation groups, so that people who were intent on using the system to access their GP felt not only that they understood the system that they were offered, but could maybe shape that system to meet their needs. And Jason is absolutely right that digital contact with healthcare is quite well known, quite well advanced in the developed world. I think what the NHS has been good at, and you'll see in the appendix on the online consultation procurement, the work that we're really trying to do to ask patients what their experience is, if their experience has been poor, why, what additional features they would want to see in the system. And of course, picking up Steve's point, I think, about Hillingdon being a heterogeneous and a mixed and a diverse community, the different needs of different age groups and different demographics within Hillingdon. I mean, there's lots of jargon around, of course, the IT tool. We've tried to put out in Section 4 some of the definitions of what online consultation is, ways of accessing a choice of appointments, whether that's video, whether that's email, whether that's online appointments. And I think radiating out from that, there are then benefits for general practice in streaming some of the admin inquiries that would previously have required a face-to-face appointment, getting a sick note or getting a travel vaccination or whatever. And there are certainly benefits for patients as well. Patients can access their practice 24 hours a day. They won't necessarily get a reply 24 hours a day, but they can put their request in at any time that suits them. And certainly in working hours, they can access the practice immediately rather than trying to navigate the telephone system and get an appointment. I think, as you were mentioning, Chairman, during the pandemic, online consultation, digital facilities really came into their own. General practice was able to stay open right through the pandemic, to be available to patients on phone, through video consultations, through digital inquiries. And of course, we did a lot. I mean, Hillingdon was the first in the country to develop the remote monitoring hubs for COVID patients, so the patients could be able to take their own tests and transmit those to an online clinic. And we're looking to develop that further in the coming years. I guess it's important to say that, like any tool and like any digital tool, it is not a magic wand. It's not going to be universally loved by everybody, and it's not necessarily going to change people's lives unless other things happen. So without question, some practices do not like online consultations. They've had to go further than maybe they wanted to in adapting their own working practice. And it's certainly true that some patients don't like using computers or using their phone to access their practice. I think what we've tried to do, and you'll see from the appendix, what we've tried to do is to engage a lot of patients and patient groups within Hillingdon. Healthwatch Hillingdon have really worked with us to help develop surveys, to help call together groups, to capture ideas from communities. And Dan West, I know if he wasn't committed elsewhere, would have wanted to join this discussion and answer any questions that you had about that. But I think that the technology itself has moved on significantly over the last 3 years. When we were first procuring GP consultation software, the e-consult system that virtually every practice in Hillingdon uses, and virtually every PCN and practice across North West London is using. We're now re-procuring that system, so there may well be a different system in place in 6 months' time, and the technology will have moved to reflect what is physically possible, what is digitally possible, and also what patients and what practitioners have been asking for. And I think that is really exciting, that healthcare is being quite open to how technology can change. It's not just that the bank gives you the system that all customers have to use in order to access their account. It's really trying to get dialogue with patients and communities about what they want. And I think maybe, I know Vanessa will have views on this. I think there are really interesting opportunities for clients with mental health problems to be using online consultations, private and confidential discussions that may be more supportive for some patients than the traditional, yes, you need to see a counsellor, you have 6 weeks to wait before you see the counsellor, go away and come back in 6 weeks' time. There's actually the facility for faster service and maybe more appropriate service. The only other thing that I would say, which maybe picks up Councillor Nelson's point, is that I think digital is part of that triangle for primary care. It's a really important side of the triangle, but alongside that is workforce, and we need the flexible types of workforce that Dr. Prasad was talking about. And digital also enables the workforce either to work from different parts of the patch, or maybe we've been looking at ways of clinicians returning from sickness or returning from maternity leave, being able to offer 2 or 3 sessions online when perhaps they weren't ready to pick up a 4-day, 5-day general practice. So workforce is a really important part of the triangle, and I think digital facilitates that. And the third, absolutely essential to Councillor Nelson's point, is estate, physical capacity for general practice, where patients can see their practitioner, is also really important. But of course we need estate to operate some of the digital services, And sometimes, because the estate doesn't need to meet CQC requirements for face-to-face appointments, sometimes you can offer that flexibility of digital calls, online calls, video consultations from a different space than would otherwise have been required for a high street GP surgery. I think I'm going to stop there, Chairman. There's a lot of information in the pack, but I'd really be happy to try and answer any questions that you might have.
Yeah, no, thanks, Richard. I thought what was really good was the sort of survey and the stats at the end was really great, actually, because if that's the kind of information you're collecting, which is going to help you build this sort of system, which is, technology is changing, people's expectations and experiences are changing, so that was very good to see. So I look forward to seeing how that goes. I mean, my first question is a very sort of basic question. Will people still be able to see a GP in person if they wish to?
Yes, absolutely. And it's in the paper, and I think we talked about it in one of the discussions about the winter planning, that we now have more appointments available through general practice than we did in 2019, before the pandemic. Half of those are online, but half of them are not. So there will always be a requirement for face-to-face, hands-on general practice appointment. I guess, as Dr. Prasad was saying earlier on, it's quite useful to be focusing clinical time on those patients who require face-to-face investigation and examination, and free up time where it's advice on the phone, prescription, ongoing monitoring that doesn't actually need face-to-face.
But and that'll be driven by the patient wanting, because sometimes a GP might think a patient might not need to be seen online or seen in person, but some patients actually really think that they would wish to. I mean, would the patient be able to sort of direct that?
I mean, I think what's interesting, it goes back to IT, only being a tool. Before computers, 1948, GPs did house calls. Some patients were visited by the GP who didn't necessarily need a house call. Patients have always been able to get the appointment when it was judged both by the clinician and by the patient that it was necessary. I think what we're getting into with scarcer professional time and maybe higher expectations by the patient is that negotiation between the clinician and the patient becomes more complicated. But the short answer, yes. Of course, in clinical need, and that's patient judgment of clinical need as well as the GP, then absolutely a face-to-face appointment will be available.
No, that balance is going to be a very important aspect. I mean, my personal experience is online works perfectly fine in many ways for me. But at the moment, it seems to be phone calls rather than video calls. I think if video calls were more of an option, I think that would be even better, because GPs, they must get this from their training school, but that sympathetic look from a GP is partly a powerful medicine in itself. But so I think that would sort of help in some ways if there was more moved to sort of like what we're doing tonight with Caroline, for example, having ability to see people on screens as well. So that's just my sort of personal comment. Does anybody have any questions? Okay, Simon.
Thank you, Chairman. Actually, I've got a couple of questions. The first was just a reference to the document. There was something in here on page 11, table 2.4 at the top of that page. It talks about Hillingdon, April to September 2021, top 5 e-consult categories. The second one is admin assistant. Could you just... I don't understand that. Why would somebody... Could you just explain that?
Yeah, it's a good example of where the general practice software can enable patient inquiries. For instance, getting a letter from the practice to back up whether it's a passport application or whether it's a housing issue or whether it's a travel issue. Those quite routine admin paperwork-based issues that probably are now digital anyway, that would previously have required 20 20 minutes by the patient waiting to see the GP, the 5-10 minute appointment can actually be dealt with online in 30 seconds rather than 30 minutes.
Thank you. That makes complete sense. My second question is sort of to do with what the chairman just asked about still being able to have physical visits. But I want to look at it from the other perspective, which is as people don't see their own doctor every time they visit GP surgeries, certainly gone are the days where doctors come around to your house. Do you envisage a point where you'd have specific e-surgeries that only deal with remote patients, so that the surgeries that can see physical patients would just deal with that, and then the separate surgeries just dealing with e-patients? Is that something that you're looking at?
So, I think there are no specific plans along those lines. I think within most practices, they will organise their working day along those lines, so that at the start of the day there will be, shall we say, 20 calls requiring urgent, immediate callbacks. Some of those patients will be, as it were, one-off needs for a particular acute episode, and that any clinician in the practice could deal with that, and so they are triaged to the appropriate clinician. Some of those urgent calls will be well known to the practice. They might be a palliative care patient, they might be a family with a child with learning difficulties. It will be well known to the practice, and there would probably be a named clinician who would be knowing the family, and they would pick up that call, or perhaps arrange an appointment later in the day. There might be other calls that come in during the day which can be dealt with by a clinician sitting by the phone, who may or may not know the patient, but who can see the records, who can see the history. That happens within the same building, but as you say, technically could be managed by another practice within the same primary care network. And that rather relates to Caroline's point earlier on about primary care surge. At times of either particular accident, that one practice is out of action for a couple of days for whatever use, or simply because of sheer demand, calls from one practice can be diverted to other practices within the same primary care network. The records can be accessed safely and confidentially within the primary care network, and so care can be given. But I think what you're touching on is absolutely the way general practice is going, is understanding the needs of their 5,000 or 10,000 population, maybe in much more detail, maybe stratified in a bit more detail, and providing the right care for the young family on the one hand, the older clients with dementia and heart failure on the other, and the one-off acute episodes that need care. So all that richness and complexity in general practice could maybe be directed in the right direction more effectively than simply one receptionist picking up the phone and dealing with everybody in a queue.
That's exactly what I meant. Thank you. Thanks, Chairman.
Aaron? Has the system been open to misuse? So the e-consult. I know for a fact I operate as a first responder, and I get a lot of people who ring 999 and say they're having chest pains and they're not, and you arrive and they've just got indigestion and they're sitting there. With the e-consult, will that just automatically pick up if someone puts chest pains? Will it automatically tell them to come in? If so, how much misuse has there been?
So it's often difficult to analyse deliberate misuse or faulty triage systems. You'll know really well with NHS 111 the difficulties they've been having about the diagnostic triage. I think again it's a tool. It's seen by some patients as a gatekeeping way into the service, and for patients, I mean, for every patient at every time, their problem, their issue is the most urgent, and the most urgent that the practice has, and therefore needs to be seen immediately. And often they're right, but sometimes they need to be seen in order. And there is no doubt that some of the early triage systems, it was able to bypass to get a GP callback by pressing acute pain, chest pain, difficulty breathing, and so on. To be honest, I don't know what the way through that is, because clearly an effective triage system needs to respond. Just as as you're saying, the 999 call doesn't truly know the condition of the patient calling. I guess there is value in the software of knowing the patients and the practice, knowing their record, knowing their history. So it would be quite simple, after they've made a couple of those calls for a flag to be put on the system. But I think to be honest, the amount of genuine misuse is tiny.
Thank you, Chairman. I've got one more. Have you found that there's a larger number of GP surgeries that use the e-consult? Because I've had a number of residents who have rung up with ongoing problems and they just need a repeat prescription and have been pointed straight in the way of e-consult, and then they've had to go through the rigmarole of going all through and then still having to go and see the GP. I know for a fact that 2 surgeries in my ward have had this issue.
I'd be interested to look at that offline, because a simple repeat prescription request should be able to be dealt with by email alone and shouldn't be being directed through the triage system. There might be reasons because of the patient history or perhaps because of change in medication that the GP was saying, no, this is your 3rd repeat prescription, we actually need to examine you before renewing it because of the change in medication.
It wouldn't have been a case of like the GP surgery was just trying to clear the phone lines. That's what I'm trying to get at. They're not using it.
No, because I mean, that would add to their work rather than. No. But no, I mean, if there are specific issues, I mean, do raise them up with me. I'd like to look at them. Yeah.
Peter.
Thank you, Chairman. Thank you for the report. Looks like we had the head start prior to the pandemic, which is excellent, and it's been a useful tool. But I don't think anything will beat face-to-face GPs. Services. On page 10, 108 consultations between April and September is an impressive amount of consultations. Out of those 108, is there data on how many did need to see the GP through that? Is it a high uptake of seeing them face to face, or was the matter resolved via e-consult?
So that's a really good question, and I think we've got some data as to how many. I don't know, Kirsty, if you've got anything more.
Yeah, from the CCG. Get these, sorry. So from a CCG perspective, we do get data from. We don't get patient level, but we get the breakdown of actually out of those for each practice, how many actually converted into being seen face to face, how many converted into actually could have gone to a different community service. So there is a breakdown. I think a majority of them, if I'm honest, actually can be dealt with over that e-consult. So it is just a case of an order of prescription, repeat, and actually Richard's correct in saying from your previous bit is that actually some of them divert them to e-consult purely because it's like a message on their system anyway, which actually generates the patient to actually, you can use this service which will get seen quicker. Now, if the patient calls, absolutely they can have the option to also say to the GP, I'd like to be seen face-to-face. So at the GP perspective as well, they will say, okay, yep, the next face-to-face appointment is on this day, etc. Now, with the data, absolutely, I think there's so much you can break down to, and I think there's so many, it's understanding when you're doing the e-consult as well, like Richard rightly said, and I think Darren was saying, part of your question around when you do an e-consult, it also depends on what the patient is putting in that system, which will trigger where they need to be seen. So it will say to you, I don't know if anyone's used it here, but if you go onto e-consult and you put admin. You click on admin, you say, okay, what's the issue? Okay, repeat prescription. Yep, go through to the practice will review it. Now that will be the case for them to come back and say, we need to see you because we've done three repeats already. Or it could be actually the patient's got chest pain, straight to 111 or straight to A&E. So I think it's also what you put in the system to what it triggers the patient to do. And I think back to a few other questions, it really does. It's down to the patient, and I think the patient's not going to know what the actual issue is, so they're just going to put what they think. And I think, but definitely from a primary care perspective, where I work with GP practices on a daily basis, they are pushing a lot of trying to see face-to-face, but actually pushing the e-consult through the online telephone messaging. It is really reducing the workload in regards to admin, like you asked what was part of that. And it's giving more time for them to free up for their 111 slots, but actually to see the patients face-to-face that require it. So I hope that answers your question in a bit more depth.
Yes, thank you. Just to follow up on the face-to-face, it says virtually all practices across Hillingdon are using e-consult. Is there any of this data broken down ward by ward, or is certain areas using it more than other areas? I only say that because my GP surgery has not. I don't think we're using it. Ours is just a telephone consultation type of situation. So
well, we could maybe have a discussion afterwards. What I meant by that was that one practice is using the Egerton software rather than e-consultants. It's just a different model. But yes, in principle, we could certainly break down practice by practice, PCN by PCN use of online consultations. To be honest, it is pretty uniform across the borough, and given the diverse communities and the difference in patient groups, there actually isn't that significant difference between the use of online consultation that one might expect. But I'm sure if you're interested, I'm sure we could find that.
Me personally, I've not come across the app yet. It's not been advertised on GP Surgery or anything, so
okay.
I'll have a look out for it.
Okay. I'm sure Kirsty, who works in the primary care team, was very happy to pick up your details on that. No, that's right. We won't mention your name.
Yeah. So I think it's also, from a primary care perspective, you've got to look at your population as well for your practice. So certain practices within Hillingdon as well have a larger population of elderly. So actually, a lot of it will be phone calls. So that's why they're probably just saying, phone calls are easier, because the majority, 80% of their population could be elderly, and as we know, there is a kind of a digital barrier for some elderly patients. So I think it's down to that, but absolutely we can, there's, like Caroline was saying earlier, with any data, the more we up our digital, the more we can really drill down into things. So you can pick up every point of it and then drill it down more. So the more digital comes out, the more it bumps up the data that we can produce.
Thank you.
Thank you, Richard. I think it's working brilliant for my GP anyway. Just one little nip on it, because the face-to-face consultation, of face-to-face speaking to GP and wanting to get an appointment, when you go on the console, doesn't always work. So you still have to make that phone call. My main concern about that is that the long time, if it's not an emergency, you have to wait to get an appointment. Perhaps once that's free up maybe your time, it will come down to a level that is appropriate. Like you call today, you might get an appointment 2 days down the line, not another 2 weeks you have to wait. So that's one of my main concerns. But I just want to say, give some praise to the team around the GP services in regards to phlebotomy, in regards to pharmacy, because I'm now accessing those services, and they're literally calling me to invite me for these things, which I thought, wow. I was called the other day to update about my medication, a review. When I went in for the pharmacy, I said, oh, wow, good. So it really is working with some GP. I'm concerned about those GPs that don't have it in the system, and also explaining it to their patients the way it works to help them to understand that it's a much quicker service that way than coming face-to-face or wanting to speak to the receptionist, because they do have a very heavy job to do as well.
Yes, thank you. That's really helpful. And I think that point about the proactive outreach to patients is also what's really promising about the population health management work. And we've seen it at first hand with the vaccination program over the last 9 months. Clearly, there are many parts of the population who will step forward and come for their vaccination immediately. That there will be others and other communities and other areas who will wait and will need a bit more information about where or why the vaccine is important or how, and that proactive contact, often going via community groups or faith groups, is helpful in putting the health message across. And we're beginning to look at how we can set that vaccine message within the broader health and well-being message, because it is often the individuals who aren't coming forward for their vaccine, who aren't coming forward for their cervical smear, or who aren't coming in for their health check, or who have, it's maybe difficult to get the children's immunisations. And again, that proactive call from the practice, with the digital record just reminding that those checks haven't been done, just helps to close the circle. And I think, genuinely makes integrated care a reality, because there's a dialogue, isn't there, between the service and the patient in a really productive way.
Thank you. Hina.
Thank you, Chairman. Thank you for the presentation. It sounds like there's so many positive elements to the digital aspect to it. I just wanted to pick up on one point that's in the report here, and it says that the digital triage form doesn't have a satisfactory translation facility. Is that something that's being developed at the moment, and where are we with it? Thank you.
Well, it's a really interesting question, and it's something that NHS London has brought to the attention of the software providers, and it's of particular interest to Hillingdon. I discovered for the first time the other day something that I'm sure you knew for a while, that the ONS census has 107 language categories in the census. Hillingdon is the only borough in London where every single one of those 107 boxes is ticked. And so the language diversity in a borough like Hillingdon is going to be quite difficult even for an advanced health software translation facility. But I still think we can do better than we are. We've talked to the software companies about where verbal translation isn't possible, is there other graphics, other illustrations that could be used, and clearly that's helpful, but it only goes part of the way. It's something we're still working out. We've been talking to Healthwatch about it as well, and at the moment there's no obvious solution any more than there would be on the telephone or in a face-to-face appointment. But we really are looking at it, because we've seen with Google Translate, but in principle there would be a way of a digital facility making a better connection and a better translation. But at the moment, rather as Councillor Davis was saying, we want to go step by step to make sure that the health access and the information based on the information the patient gives is as accurate as possible. And that's good.
Thank you. Fantastic. Thank you, Richard. And I think this is obviously a subject, I think, again, at some point next year, we'll probably want to have a look at again once we know the system is being put in place, more of the data is being collected. So, let's move on to agenda item 7, which is phlebotomy. Richard, this is you again, isn't it?
It is. Thank you very much, and I'm very grateful for Kirsty and Peter done a great deal of work in transferring the phlebotomy requests from the hospitals to clinical practice. I'll be brief on this, Chairman. We discussed the phlebotomy proposal, I think back in July, and Nick attached the original paper to your papers. And there, we were really pleased to report the progress in transferring hospital-based phlebotomy to general practice, which in itself was a logistical challenge in moving from 1 or 2 centres to 40 right across the borough. But of course also we've been really well received by patients that they no longer had to go to hospital, they no longer had to wait the waiting time in the queues and so on, partly risky, but it was to do with the COVID situation, but it was much shorter in general practice. So it just seems finally to bring an update to you and just to report on where we've been moving forward on some of those proposals, and we've got specific actions that we want your thoughts on. Every practice and every PPN now has practice-based phlebotomy available, and you'll see from the table, table 1 and table 2, the way the general practice activity is increased and the hospital compliance activity has decreased over the last couple of quarters. Being in healthcare, nothing is entirely simple and easy extrapolation because during the autumn there was also a national shortage of the little battery container that was blood kept on, so that nobody, whether hospital or community-based or practice, could take as much blood as they expected. So that does distort the figures a little bit. But we think we're now in a position to stand down the routine blood testing service at Mount Vernon, and that's partly because demand is tailing off, and also because of the space within Mount Vernon. They have moved the hospital clinic, I believe, twice, 2 smaller spaces, and in any case, as Jason would have told us, with the DPAN for the FHC development, that space would again have been moved. So we're proposing to stand down the routine service at Mount Vernon probably during March. And what currently, and this is something really that's developed as a result of general practice successfully taking the team test. We've been looking at offering an urgent service through general practice. And urgent meaning that the clinician needs the results that same day in order to change, potentially change clinical management. It's not urgent in the sense that every patient is urgent and every GP wants everything done immediately. So the numbers will be relatively small. And we've looked at a couple of options that Kirsty is consulting practice at the moment as to whether every practice will take those urgent checks in the morning so that they can get to the lab in time for reporting, or whether we'll develop a more PPN update service for that particular patient right through the day before the lab needs to get started. So we could very much get your thoughts on both of those and also the change the use of the microphone facility. I think not anything else to add to the paper, but I'd be happy to answer any questions. I think this it's just one more stepping stone in the way of equipping general practice, equipping community services to undertake more diagnostics, to be more self-sustaining, and then to reach into community service self-sustaining services for the expert advice they need, and that's got to be the right way of
Is that a metaphor for this meeting? Sorry, the screen. But anyway, Richard, thank you very much for bringing this back. We were very supportive about the idea when you brought it to us last time. We had a few questions about how it might work in practice, but the report sort of deals with a lot of those. In terms of the question you asked, I really don't know. Whatever delivers the best possible service that people want, I suppose, and the fact you're asking people helps. So, no, I think the direction of travel seems to be good. Does anybody have any questions specifically? Oh, fine.
Thank you, Chairman. I have to say, I think this should have been done years and years and years ago. Having been to Hillingdon Hospital to get blood taken, and even if you get that 7th, in fact, it says so in the report, you get that at 7:30 in the morning, you're still waiting an hour. So long do I hope this continues. Sorry, that's all I had to say. Thank you, Chairman.
Great. Okay.
Thank you very much. We're very pleased to hear that.
I agree. Right. Thank you, Richard. Okay, and you may leave if you wish to, and anybody else may leave, because we've got 2 more agenda items. Okay, yeah, brilliant, fantastic. Right, okay, hopefully the next 2 agenda items will be pretty quick anyway. So agenda item 8, basically the paper is for noting, because I wanted the committee to see sort of some highlights of the evidence that me and Nikki have collected over the last few months on the issue of police and mental health attendance and A&E. And it's just to sort of reaffirm that actually I think this would be quite an important and useful issue for us to look at our June meeting. So are we happy to look at this issue at our June meeting? Fantastic. So I have nothing on that. Brilliant, fantastic. And
sorry, Chair, can I just
Yes,
come
of course,
in?
Vanessa, yes, of course.
So I just wanted to say that I've actually started setting up meetings anyway with various people, including the Met Police. So it may be that we're in a position to actually bring something to the June meeting, if that would be helpful.
That would be absolutely fantastic and awesome. So yeah, no, that'd be really good. Thank you very much, Vanessa. That's because Vanessa's one of the people we spoke to very early on in this, actually. So thank you. That is really useful. And on agenda item 9, our work programme, we had quite a big discussion about this at our last meeting. So I just propose that we agree it as it is at the moment. Yeah, fantastic. Okay, brilliant. So I now call this meeting to a close. Thank you all the attendees, including Caroline, who you're on a little screen now, but I can still see you. That's okay. So thank you to everyone who attended, and I'll call this meeting to a close.